So I encourage any of you to come up and ask questions. And while some of you come up, I'd like to start by asking the panel, what's your definition of clinical site success? What's your ask? How many patients would you realistically like to see treated in your perfect practice? So maybe each of you can address that question.
I'll start from let me just compare. I believe in comparators. So comparison in a surgical practice is the surgeons want to be busy and they feel like they're exhausted at the end of the day, they had a good day. So that usually is 2 days a week. We know that for the traditional patient for this prostate treatment, we'll be looking at about a 2 to 3 hour patient encounter period. So that would be a 2 to maybe 3 cases per day. And I think considering that we'll have the technology available continually, we potentially would want to be active weekly. That would be a great sign of success.
Okay.
Yeah. So we've been doing procedures once a week for a while now, sometimes twice a week. There's a number of issues that have to be addressed. One is on a given day, how long does the procedure last? Being able to have access to the MR scanner. For these treatments, for example, with essential tremor, where it's a collaborative treatment with the neurosurgeon and me, obviously both of us have to be available, and there's a lot of demands on both of our times. I think we've talked about this a little bit internally already, and as a starting point, we'd like to be able to do 1 or 2 days a week where we're doing, let's say, neurosurgical treatments, and hopefully we can do 1 or 2 during each of those days just to maximize, the time of the various physicians and the scanner time and so forth. There's more complicated issues. Obviously, reimbursement matters in terms of justifying that time on the scanner, justifying the time of the neurosurgeon who could be doing something else very valuable. My time, I could be reading scans. So all those things have to add up to making it worth the time of the individuals there. Clinically, it's an easy sell. Obviously, the technology works great for these guys with tremor, but financially for the hospital, it has to be addressed as well.
So Peggy, at your institution where you cross multiple disciplines, can you envision 1 or 2 days a week during tremor cases, 1 or 2 days a week doing fibroid cases, 1 or 2 days a week during desmoids? And would you, if other people are trained to do this, have the scanner pretty much dedicated towards focused ultrasound procedures across multiple disciplines all week? Do you think that's a realistic possibility?
Some of my more tiring weeks, but some of my favorite weeks, I've had a week where in 7 days I've done a prostate, a bone, a fibroid, a brain. That's an exciting week. I get to do a little bit of everything, and it's fun to see the results. So a dedicated magnet, we're expanding our hospital and new magnets are going in, and so one of the plans is to have an interventional magnet that'll relieve the capacity constraints that we have. I think that's a major impediment right now to growth. Training other folks, as you mentioned as well, both internally and externally, having new faculty come on that are going to learn the neurosurgical procedure, people to learn the prostate procedure. So it's not just dependent on me, but that we have other in-house experts that can help. Those are all going to be part of the growth process and necessary. But I think having a dedicated magnet makes a big difference. Just because otherwise there's a tremendous demand for that magnet. If there's cases piling up in the ER, they want you to get done so they can start scanning patients.
Okay. Doctor.
In fibroids, it depends on size, of course, in cases. We try to do treatments 3 times a week. 3 times a week.
3 treatments a week?
Yes.
And can you envision in your practice doing more? Would you have the capacity to do more?
It depends of reimbursement, of course. We don't have reimbursement. We have a just research grant for 300 cases. So we'll see what will be in future.
Okay.
So one comment. This problem exists for the robot. So when the Da Vinci became available a decade ago, there was one user at Duke who was a thoracic surgeon. He was using it for research. He left the faculty and left the robot in the corner and gathered dust. It came back, and the urologist decided they should try it, and then, as we know, that exploded. So now we have 6 different clinical disciplines using the robot at our institution, and we have 2 robots. Our neighbor has 3 robots, and I'm sure there are institutions with 5 robots. We have a robotic committee. The committee meets monthly. Utilization rates are reviewed frequently, quarterly, and robotic privileges are adjusted. And it's become a necessary process because of the demand, and I think this could easily occur for a fixed unit with multi-purpose functionality.
Right, right. I'd like to share my experience a little bit. I'm in a private practice in Boca Raton, Florida. We have 4 MRI machines, one of which has the focused ultrasound unit. In the coming weeks, I have about 3 or 4 focused ultrasound cases scheduled and numerous consults scheduled, but my ask and my dream would be to do 10 cases a week, 2 cases a day on that magnet. So I have lofty goals, but I think specifically with fibroids, that's possible, but especially when you're at a university hospital where you can have multiple disciplines coming in to do different treatment applications on different days, I think that's something we should aspire to and think about. So now that we all know we want to do multiple cases and we have the clinical teams and the people necessary, the next question is the reimbursement issue, right? Yes. So going from research dollars to clinical dollars to individual applications to insurance companies for individual cases to cash payers. Right? So how do we ask patients to pay for these procedures out of pocket? How much should we expect from that versus insurance reimbursement? So I'd like your opinions on how we can make this more accessible by getting the reimbursements and how we approach that topic with patients.
So first, we have a fibroid unit at Duke that's been there for 10 years, and in my recent discussion with the technology committee in gaining approval for our prostate device, it was revealed to me that the financial arrangements had been in place for that time. That includes financial counseling and, to some degree, some credit arrangements. But I think this is a big issue because this needs to be disclosed completely early in the process, even at the time of eligibility screening. And since I'm going to say I don't have the long-term track record of that, we were able to receive support for our research study patient subjects in about half the cases. So I do believe in transparency disclosure early.
For bones, where the bone metastases, where with level 1 evidence and not just the FDA approval, but also now insurance coverage across some of the major carriers, also with Medicare coverage, most of those patients, I haven't had any issues for quite a few years now getting reimbursements for bone metastasis treatment. Surprisingly, I've had very little issue with some of the off-label applications in osteoblastoma and vascular malformations. I'm not 100% sure why. With desmoids, like I said, each case is its own appeals case. For fibroids, to kind of go back to your original question, the issue that we had with the clinic, the fibroid center, is that you'd eventually get to this conversation of, well, you're a great candidate for FUS, but insurance is going to be an appeals process. It might take 6 months. It might be, may or may not be successful. And then the patient said, well, I can get a surgery within the month. I can get a UAE within the month. Why should I wait 6 months and then find out that I could get the surgery, end up having to have the surgery that I could have now? So what we have ended up doing is in order to be fair to the patient, we came up with a number. Our financial people in the hospital really bought into the value of the procedure itself for the patient. The fact that the patient's able to go home quickly, the quick return to work, and so forth. And so what they ended up doing is coming up with a number that is similar to what their copayment might have been for a surgery, for example, and saying, okay, if you can afford a copayment for the surgery, you can afford this payment for this procedure. It's a dramatic reduction in the actual charge, and that allows the patient to go ahead and get the procedure done now. It eliminates the financial aspect of which procedure they get. Now they get to choose whatever procedure that is the doctor and the patient feels best for them. And then on the back end, we'll go through the process of asking for insurance authorization, and sometimes that works and sometimes it doesn't. But if it does work, then the patient gets their some portion of their money back if they paid more than they would have for the deductible. If it doesn't work, it limits what their kind of out-of-pocket is. And I think if you average all that out, sometimes it's the patient's payment, sometimes the insurance pays, and it averages out, and hopefully it averages out to some number that's palatable to the hospital. And I think also the hospital is smart enough to look at what I was saying before about how by offering a number of different treatment options, including FUS, they see a growth in these other areas. And so when their surgeons are doing more myomectomies, when their interventionalists are doing more embolization, some of that is because patients come in asking about FUS and realize they're not good candidates for it, and then get to talk about these other options, and so everybody else is benefiting. And so some amount of that credit goes back to FUS.
Right. So both of your comments together are very interesting. Number one, there's a lot of transparency involved when you're asking patients to potentially pay for patients, and I think that's really important to set up right at the beginning. And what Dr. Nooney was saying is that a lot of times their out-of-pocket expenses match or perhaps even less than their deductible. So they get a choice on how they want to spend their money, and they get a choice when they're educated about the treatment options, which one is best for them with the risks and benefits of that. So that's a really important concept, I think, for people to take home from this. And Dr. Lazinski?
In Poland, unfortunately, reimbursement by the national health insurance is impossible now, so we can only receive a research grant for.
So I'm sorry, I couldn't. They do pay or they do not pay?
Not pay.
Do not pay.
Not pay. No, it's impossible. Not yet. And we hope to start a bone metastasis treatment, but after receiving some grant.
Okay. Any questions from the audience?
On the reimbursement, in the U.S. for the prostate cancer specifically, regardless of the device, most patients are paying about $25,000 cash for the procedure. I would estimate among U.S. patients that over the past 10 years or so, the total number of patients that have been treated has been about 6,000. Now, to put that in perspective, back in the early days of proton therapy for prostate cancer at Loma Linda, they were charging $50,000 to $75,000 per patient to be treated, and they were treating in excess of 1,500 to 2,000 patients a year. So the reason for bringing this up is I don't think people should be discouraged from exploring these technologies because of the fact that they are cash pay. I think we do need to explore how to get the technology to the greatest number of patients, and that may be reimbursement. To put it in perspective, in Europe, in England, the public health system pays about $10,000 for prostate cancer. In Switzerland, it's about $8,000 to $9,000. In Germany, it's about $3,000 to $4,000.
Okay, thank you.
Well, the $15,000 to $25,000 for prostate cancer here paid in the U.S. out of the pocket. That's put that into perspective. Prostate cancer patients are older male who have the liquidity usually, and when we're talking about other diseases like osteodysteomas are young patients, or uterine fibroids are often younger women who cannot cover that kind of money. So there we really depend on getting some statutory reimbursement in place and getting some more international flavor to the discussion here. So in different countries there are different regimes, and in some countries there is reimbursement. So in Korea we have cases, if you haven't been there last night, I'm the marketing guy for Philips, and in Korea we have cases where there is reimbursement, where gynecology, women's health hospitals buy the technology, buy their first MR systems to treat uterine fibroid patients with focused ultrasound. So getting reimbursement is actually the key question to make a site successful, besides all these points of collaboration, which we all very much emphasize and support.
Mm-hmm. Thanks for your comments, and I think you're absolutely right. Getting a widespread insurance coverage and adoption is key to all this, and that's a whole nother hour conversation on how to go about getting the insurance reimbursement, but I appreciate your comments on that. Are there any other questions or for the panel or comments?
I would make one comment, and that is the whole issue of reimbursement is also determined to some degree about the coding and whether actual diagnostic and therapeutic coding goes forward in a regulatory fashion. And I'd love to hear the comments from our industry representatives about the impact of coding or having no code or an unlisted code, and what your experience was having an unlisted code early on.
We've had this discussion at the prostate level, and it is a dilemma, because for the hospital or the practice looking to purchase the equipment, having a $25,000 charge that they make means that they pay back their investment over a short period of time. So if they're an early adopter and they're able to get the patients to come, then they're in good shape. It's the later adopters of the technology that are faced with a situation where they now are in a situation where there is reimbursement. It takes them longer and a greater number of patients to be able to pay back. On the kidney side, for instance, there are kidney ablation codes for HIFU. There's no payment associated with it, but there is a code. Now, it's never been used because HIFU hasn't been used in the United States for kidney cancer yet. So there are ways to co-opt codes that exist. On the prostate side, there aren't any. And I think, at least as speaking as a manufacturer, we basically look to clinicians. When the clinicians say to us or the users say to us, we want a code, then that increases the effort that we need to put forth to ensure that happens. At this point in time, it's not clear what direction people want to go in.
Yeah. Well, I believe we've met the time. It's 11:15, so that ends this session. I appreciate you for coming, and I hope that these experts up here have given you advice on how to go back and make your sites successful as well. So thank you.
Thank you.